Chapter 14, Devita, Cancer of the Colon. Today we will see the risk factors and the environmental risk factors. Seminal studies have understood the importance of environmental factors as contributing to the pathogenesis of colorectal cancer, and one has to take population-based studies into the context of methodological employed, lead time bias, time lag issue, definition of surrogate and true endpoints, and the role of susceptibility factors. One such population-based study recently evaluated risk factors for colorectal cancer from the Women's Health Initiative, a comprehensive prospectively collected database of 150,912 postmenopausal women, in which 1210 developed colon cancer and 282 developed rectal cancer. 11 risk factors were independently associated with colon cancer, and some of which have a little or no previous support in literature, like age, waist, girth, use of hormonal therapy at baseline, years smoked, that is protective, years smoked, arthritis, protective presumably due to medications use, relatives with colorectal cancer and lower hematocrit levels, fatigue, diabetes, use of sleep medications, and cholecystectomy. And the three these factors were also significantly associated with the increased risk of rectal cancer, age, waist girth, and not taking hormonal therapy. So diet. If we talk about the diet, total calories like obesity and total calorie intake, they are independent risk factor for colorectal cancer as revealed by cohort and case control studies. An increased body mass may result in a twofold increase in the colorectal cancer risk, with a strong association in men with colon but not rectal cancer. Weight gains during early or mid adulthood has also recently been linked with increased risk of colon but not rectal cancer, and this relative relationship too seems more prominent in men than in women in a large prospective study. Then meat, fat, and protein. So ingestion of red meat but not white meat is associated with an increased risk of colorectal cancer, and as such per capita consumption of red meat is a protein independent risk factor. Whether the total abstinence from the red meat leads to decreased colorectal cancer incidence has not been clarified, as there are studies with opposing results, and also unclear is whether the type of red meat or the degree of processing or cooking method may make any difference. While Probst Hans et al. Found fried barbecued processed meats to be associated with a colorectal cancer risk, especially for rectal cancer, and with odds ratio of 6. Follow-up reports do not consistently support these claims. And in this population-based Norwegian women and cancer cohort, including 84,538 participants, highly processed meat intake, like especially sausage, was associated with an increased colorectal cancer risk, but meat cooking method and total meat intake were not. And a second study of 50,000 participants reported no difference in the processed meat intake either, and the authors did find the cancer risk was associated with different meat types like animal of origin, which varied by tumor location. Specifically, colon cancer risk was significantly limited in Sentikong high lamb intake, and the incidence ratio of rate ratio of 1.07. Rectal cancer risk was affected by pork, and McCulling et al. Recently reported positive association in patients with non-metastatic colorectal cancer between the red and processed meat consumption before cancer diagnosis, with higher risk of death after definitive surgery. Second is coffee. So coffee contains numerous bioactive compounds that may modulate cancer risk, but previous epidemiological studies investigating its role in colorectal cancer have yielded ambiguous results. In recent meta-analysis of 41 studies, Lee et al. Found significant inverse association from case control data from colorectal and colon cancer but not rectal cancer, and this was particularly true among female and in Europe. Stronger evidence comes from the National Institute of Health and cohort including 4,89,000 members And in this report, both caffeinated and decaffeinated coffee drinkers had a decreased risk of colon cancer, particularly of proximal tumor, for more than 6 cups a day. And a decaffeinated coffee drinkers also had a decreased risk of rectal cancer. While known co-founders such as smoking and red meat consumption were adjusted for, further investigation is warranted to confirm the clarity. Then fibers. High fiber diet was associated with a low incidence of colorectal cancer, with numerous studies sustaining this premise, and protection was believed to be afforded from the wheat bran, fruit, vegetables, and a high fiber diet was believed to dilute fecal carcinogens and decrease colon transit time. Generate a favorable human luminal environment. The European prospective investigation into cancer and nutrition is an ongoing multi-center prospective cohort study, which was one of the largest and most influential studies to initiate a report to investigate association between dietary fiber and colorectal cancer. More long-term data with a mean follow-up of 11 years and a near threefold increase in colorectal cancer cases further supports this claim, while providing a more precise estimation of fiber food sources as well. After multivariate adjustments, total dietary fiber were found to be inversely associated with both colon and rectal cancer, and this did not differ by age, sex, lifestyle, or other dietary factors. However, other large, well-controlled studies show no inverse relationship between colorectal and fiber intake. So this was further collaborated with the two randomized control studies evaluating high fiber diet for moderate duration and discovered a lack of effect on the number, size, histology of polyp found on colonoscopy, and at this point there is unclear whether dietary fiber plays any substantial role in the risk of developing colorectal cancer. If we talk about vegetables and fruits, a protective effect of vegetables and fruits against colorectal cancer is generally believed to be true, and this has been observed by raw, green, cruciferous vegetables, whether certain agents such as antioxidants, vitamin C, E, A, folate, thioethers, terpenes, and plant phenols may translate into effective chemo preventive strategies requiring further investigation, although data for folate intake are sound. In addition to folate, dietary methionine that has also been methionine is a compound one carbon metabolism recently been shown to impact the risk of colorectal cancer. Zhu et al. They performed a meta-analysis of 431,000 patients participants and 6,311 cancer cases, reporting an inverse association between the two, particularly the studies with long follow-up. And taking this nutritional data a step further, Bamia et al. Recently evaluated the impact of Mediterranean diet on colorectal cancer. The diet introduced in 1960, a health protecting, include high intake of vegetables, fruits, nuts, fish, cereals, legumes, with moderate intake of alcohol consumption and low consumption of dairy and meat. And the authors found 8 to 11% decreased colorectal cancer risk when comparing patients with highest to low diet adherent rates. The association was strongest among women and colon cancer. So another approach of dietary risk assessment emphasizes the specific certain foods on inflammation. The Dietary Inflammation Index, DII, is a literature review based score that was developed and validated over the past several years, comprising of 45 food parameters with varying effect on specific inflammatory factors such as interleukin 1, 4, 6, 10 and interferon alpha and CRP. And the number of recent studies have demonstrated an association between this dietary inflammatory index and the colorectal cancer. And in a case study found 424 patients with colorectal cancer and 401 control, direct association was observed between this dietary inflammatory index score and colorectal cancer, with even stronger findings of colon cancer alone. And Tabung et al. Reported a similar finding in prospective analysis of using 152,000 racially and geographically diverse postmenopausal women, and when the tumors were differentiated by site, only proximal colon cancer retained a significant risk association with elevated DII of 1.35, whereas no impact was demonstrated for distal colon or rectal cancer. So other dietary factors such as investigation include calcium, magnesium, vitamin D. Calcium has been historically implicated as a protecting effect, perhaps due to its ability to bind with injurious bile acids with reduction in colonic epithelial protection, and this is supported through cell culture model. In 2013 case control study of 1556 patients from Poland, and after adjusting from various dietary and lifestyle factors, authors reported that an increase in calcium consumption was associated with a decreased risk of colon but not rectal cancer. So subjects who consume more than 1000 milligram per day showed a 46% decreased rate of colon cancer. And a recent meta-analysis evaluating the influence of magnesium intake demonstrated a modest risk reduction with the pooled risk reduction of 0.81 for colon and 90.94 for rectal. So vitamin D has been shown to inhibit cell proliferation and increase apoptosis in vitro, and its deficiency is an important risk factor for many types of solid cancer. So meta-analysis of 18 prospective studies, vitamin D intake and blood 25-hydroxycholecalciferol levels were found to be inversely associated with the risk of colorectal cancer. So this report's preliminary observation data, large randomized trial of vitamin D supplementations are warranted and would be needed for routine vitamin D supplementation could be recommended for the purpose of colorectal cancer prevention. And it is not worthy that the Institute of Medicine, while supporting vitamin D supplementation to maintain the bone health, found the evidence insufficient to support the vitamin D being protective against colorectal cancer or other types. Thank you.